Very good. Welcome back. If you're just joining us, you're watching BizCheck live from Broadcasting House. Our conversation this morning. We started with the state of our economy in the face of the enduring mass demonstrations. And time now to focus and, of course, now talk about another very critical and very important issue that determines the health of us all, and that is the cost of our healthcare. You see, I was going through a report by United States Aid International, and they did a study where they discovered that about 1.2 million people slid into poverty every year because of what we call out-of-pocket expenses on healthcare. When you look at the Abuja Declaration on Health, it talks about increasing the annual budgetary allocation to the healthcare sector to about 15%. But in Kenya, we're doing about 7 to 8%. And so the question is, what is the way forward? Those are some of the issues that we want to tackle this morning. Joining us is Imran Osman. He's a Chief Executive Officer of Avenue Group, which is a healthcare group, and he's joining us so that he can help us with this discussion. Thank you very much indeed for joining us, Imran.
It's a pleasure.
And of course, we know that we are going to benefit immensely from your input. But you're telling me that there's something you would want to say in regard to the maandamanos that happened on Monday and that are projected to happen on Monday and Thursday next week. What did you want to say?
Well, I must say it's a pleasure to be here, and picking up on the topic that you've just concluded, I think it affects every one of us, every Kenyan who is hardworking, earning, and also those who are unemployed. Mm-hmm. If I reflect on what happened in 2007, I remember being in Kisumu during that time with another healthcare facility, and we had to really mobilize people and get them into areas where we were able to evacuate. Looking at Monday, as Avenue Healthcare and its hospitals across the country with 15 clinics and 3 hospitals in 6 counties, we saw a drop in patient flow by 500 patients. Now, those are 500 patients who would have otherwise come to the hospital to seek treatment and opted not to come to the hospital, perhaps due to access or perhaps due to fear of getting out. So the maandamano are affecting even access to healthcare, mm-hmm. and I hope and pray that we see some sense and conciliatory approach to this mm-hmm. in good time. Mm-hmm.
Yeah. If you are in a position to deal with this issue, how would you deal with it?
No, our previous guest talked about a cup of tea, and I think chai in Kenya is a popular thing, and I'm a Kenyan by birth and also the 4th generation, mm-hmm. So I'm Kenyan as you get, but a cup of tea makes a huge difference in talking and diffusing situations, in dialoguing. So I would approach it with dialogue, within the law, but with dialogue and make sure that we are able to get the leaders to speak and find solutions that benefit Kenyans, and I think it is within their reach to do that.
Very good. Yeah. Well, let's hope they're listening, and of course they'll heed your advice and of course the advice of the previous guests. Let's now get into the topic of the day. I want you to give us a general overview of Kenya's health sector right now.
So, good question. Kenyans, the health sector is actually provided for or catered for by the government, who is the sole owner of this, and it's their obligation. The government should provide, as part of constitution, good healthcare services. However, we also have private hospitals that actually complement the government in its services through PPP and also through independent setups across the country. It is underserved healthcare. We believe it is grossly underserved. Access and affordability is a big issue, and thereby the universal health is an important topic to discuss mm-hmm. As we go forward.
Mm-hmm. When you say that it is grossly underserved, what exactly do you mean?
So when you go to the urban areas, there are many hospitals, many clinics. However, the spectrum to which they serve is something that we must look at and compare to the disease pattern. I was reading one of the studies, and it showed that currently Kenya, in the universal health coverage, is actually covered to 50%. We hope to go to 60% of the health disease burden that Kenyans face, and we are just forecasting that we'll be able to cover only 60%. So it's important. 60% of what
will happen to the rest 40%?
So that's the question, and it's not just about accessibility. Universal healthcare by definition is to provide safe, effective, quality and essential healthcare. But that doesn't just include visiting the hospital or seeing a doctor or getting a healthcare worker to see you, but it includes affordability. It extends to essential medicines and vaccines. And I heard you say in your opening remarks that we are just one hospital admission away from poverty. So universal healthcare, by virtue, I think it's misunderstood, in my opinion. It's always assumed that it's going to be a free healthcare provision, but it's not necessarily free. It's supposed to be keep you away from poverty, but still access healthcare and healthcare services. And it doesn't mean that you only get branded medicine. It is essential medication. It is what makes a difference and attacks the disease and helps you get better.
You see, when you look at Vision 2030, it talks about ensuring there is universal health coverage by the year 2030. We are talking about 8 years from now. And when you look at what we have managed to do in the last, let me talk about 15 years since the Vision 2030 was launched. And you have put it, I mean, the health coverage today is about 53%. And so we have 47% who are outside this bracket. And this is what you call the critical mass, because they are poor of the poor. Are we likely to achieve this universal health coverage that we always talk about?
I would think if we did some things correctly, we can. And I think the government has put in great effort towards this. Devolution was one very key milestone that happened, and with the devolution, I think what we have seen is, for example, if I look at my stats, in Bomet County, for example, we had 3 hospitals, and now we have 8 facilities. We have equipment in major hospitals across the country that were under lease, and they are still there, and they can be revived. We have seen promotion of health, take center stage. Mother and child healthcare is something else that we have been seeing the government focusing on. So I think we're on the right track. We just lost momentum here and there, but there are opportunities that we can leverage on and partner with even private facilities, even non-governmental facilities that actually would be able to bridge this gap.
You're talking about retweaking some things or doing some few things right, and we'll get there. What are these things that we need to get right?
So in universal health, if we dissect it, there are a couple of things that must go right. One is accessibility. Now, if you look at what the government has done, it has built a lot of roads across the country, and especially in Kisumu, if you look at it 10 years ago and now in Eldoret, Uasin Gishu County, we've seen a lot of roads coming through, and that has shortened the distance from Kakamega to Kisumu, for example, Kakamega to Eldoret, for example. And this actually helps to bring access and healthcare closer to the patient. Quality is another key aspect where I think the government has invested, and private hospitals are also looking at investing. They've allowed institutions to get accredited, such as JCI, Joint Commission International. We have Safe Care. We have COSASA accreditation, which is a South African-based accreditation, and that uplifts the quality of care in the country. Then there is a safe medicine, safe practice. There is a lot of laws that have gone in to ensure that the doctors are actually providing safe healthcare, safe medicine, safe birth, safe deliveries, and so on. And there's been a lot of community health education that has happened. But how do we make this effective? We only make this effective if we are able to provide this service where it's required. So what we sometimes see is equipment that has been perhaps installed in a county government, and it's underutilized. Now, how do we connect that equipment to a network of other equipment and specialists where they can access and utilize it? Instead of putting that investment in a county where the prevalence of that disease may not be there, we should put it where it is and match the skills. In many areas we've seen where we have a good equipment, we have a good facility, but we have low-skilled manpower, or if we have the manpower, they are not upskilled enough to cater for and take care of that equipment and use it effectively. So we just need to match the resources to where it's required. Yeah.
You see, and I like the fact that you have put it right. In the last 10 years, we have seen a major increase in terms of health coverage in the country. We have seen our hospitals, expanding their branches, and your case study. We have also seen our universities and institutions of higher learning, churning out more professionals, more doctors, more nurses, and so forth. We have also seen a number of initiatives by both the private sector as well as the government. And a case at hand is the affordable healthcare, which was championed by the former president, Uhuru Kenyatta. The medical equipment leasing program, which you have just talked about. And despite all these, we still have almost half of Kenyans outside the healthcare coverage. What are we not getting right?
So I'll try and venture some answers there. So one is equipment maintenance. Whereas we are installing the equipment, we need to be able to maintain that equipment and services. Equipment come with their own cost. They have downtime, they have maintenance requirement, PPM, preventive plant maintenance that are required. And we have a host of engineers, biomedical engineers, who I see are coming up quite actively to support the government in maintaining this. These biomedical engineers are supposed to be redeployed and perhaps support this. There is also a supply chain of medication that perhaps I see a lot of stockouts, and whenever a new government comes in, I see they're closing that gap. But consistency is something that is lacking. Controls is something that we should invest in. And I think maybe we should start investing in customer satisfaction, that who is our customer specifically? It is the patient and the mwananchi. At Avenue, what we have done is we are trying to bring the cost of healthcare down by creating products that are predictable. So the patient walks into a hospital and mostly they don't know what to expect, and sometimes don't even know how to prepare. Many a times we have discharges, and at the discharge point, the family says, we didn't envisage this. So we're trying to create predictive models to support and constantly communicate, and even make sure that the patient is aware where they are and how we can manage their care even better. The other thing that Avenue and maybe the government is also doing, and I'll speak for Avenue right now, we are focused on promotion of healthcare, best practice, promotion of healthy lifestyle. So what we have is a continuum of care. In Avenue, what we've done is we've created something called prepaid scheme, and the prepaid scheme is such that we are able to help you get medical attention across our network of hospitals and engage with you through chronic care programs that you don't even need to go to a hospital, where you are able to improve your lifestyle and even reverse your diabetes, for example, through obesity programs and weight loss programs that lead up to even bariatric surgeries. But with the promotion, then we provide primary healthcare, tertiary and quaternary healthcare. But where I'm going to now is home-based care. Avenue also provides home-based care, and it has been providing for the past 27 years, little known to the market. And this provides, we can discharge a patient out of the hospital to home-based care. So you don't need to spend those extra 2-3 days for something that you could have managed at home. And then we deploy nurses or patient caregivers within the inpatient facility. So what we need to do perhaps to improve healthcare coverage is prevention, promotion of healthcare, If the lifestyle improves, if we are able to prevent even people from getting to the hospital through healthy lifestyle, through healthy living, I think this will bring down the cost of healthcare to the government. As you mentioned, currently we are at the Abuja declaration, looked at 15%. But last I checked, we are roughly about 9.2. It's not something to scream about. The value has increased because the pie has increased, no doubt. But the requirement is to hit 15%. But how do we target the 15%, but also manage a healthy population so that they don't need to get to the hospital and spend that, and they are catered for through nutrition, through healthy lifestyle and so on. So that's what I would do.
There is also this other aspect, and probably maybe you should help us, how we should go about this. Because when you look at, for example, the insurance coverage within our sector, you have about 20% of Kenyans, having some form of health insurance, be it through the National Health Insurance NHIF fund.
Yeah.
Then the other being the private sector and so much. But when you look at, even statistics further, it will show you that the numbers are heavily skewed towards more wealthier counties. For example, in Nairobi, almost 50% of the population in Nairobi, they have some form of health insurance. But when you go to the poor counties, and I'll pick, for example, the county of Wajir, it's only about less than 5% of the population who have health coverage, health insurance. And so in this kind of a skewed situation, then how do you ensure there is fairness, the resources are distributed fairly?
No, so the devolution of envisage that we can distribute equally across, and especially the disadvantaged or vulnerable communities that are marginalized for a long time, and that was inculcated in the constitution. I think 0.5 equitable adjustments were also put into the budget allocation. But to speak to the affordability angle, I think urban centers tend to have more insurance covered patients or patients who are covered by insurance, be it private or national hospital insurance fund, is because most of them have employment, and many people who are covered through private insurance are actually in the employment sector, and so are the people who are actually in the NHIF because they contribute, or they are forced to contribute through employers. And that disparity then in Wajir speaks for itself. But if you look at counties like Wajir, if I were to take that as an example, they are also underpinned issues such as a belief system. Yeah. So I'm a Muslim. It's Ramadan, and Ramadan Kareem to you.
Ramadan Kareem.
But there's also a divide in the Muslim community where the insurance product is seen to be not halal. So it's incidentally that you asked me this question, that Avenue has actually identified that as a gap, and how do we reach to that population that and their belief system and make a product that matches them. We just launched a product called Shifa Medical. Shifa Medical looks at how you contribute to your health even before you fall sick. As communities in estates, for example, let's say you are a bunch of 20 households in one estate, you come together, contribute a fund, we help you define a fund scheme, you are in charge of your fund on how you utilize it, and when an event happens, then you're ready. As Kenyans and also humans, we save to buy a house, we save to buy a car. We mainly save for education, not everyone, but we save for education for our children. But who starts saving for health? Our backup is always insurance, but for this vulnerable population and the Muslim society, they don't have a product for this. So Avenue has tried to reach private institutions, work with the government in creating these innovative products that also unlocks and demystifies healthcare as an expensive thing. Healthcare becomes unaffordable because when it hits us, it perhaps is too late, because we are not going through health checks, we're not going through preventive, we're not going through health dietary, and therefore when you end up in a hospital, mostly it is very severe, and sometimes it's even too late, and therefore it hits us from a bill perspective. So NHIF envisaged that already, and it looks at creating a fund progressively and building that. And I think the idea is not novel. It's worked in other countries, and we just need to piggyback on that and make it work.
Mm-hmm.
Yeah.
Is it possible to have free medical services in Kenya?
To be honest, the answer is dicey. For the government, I think it is also not free. We perceive it to be free, but it is funded through some other areas. Mm-hmm. Devolution envisaged how we devolve that fund from the big pie and put it down and trickle it down. But it's still not free. Even for the county hospitals, when you go there is subsidized rates. In the referral hospitals, you still have to pay some amount. Of course, it's not equal to private, but it's subsidized heavily. But you still have to pay for that specialist. What I think we perhaps need to change the narrative and change it to become decentralized, not devolved. Mm-hmm. When you go decentralized, then you are empowering the county governments to provide healthcare, to take up that responsibility, which they already do, but you're also asking them to generate the revenue that is required to build a sustainable model. So how are those? Those who can afford. If you uplift the county government health facilities to a level where even the private patients and those who are able to go can feel comfortable through the quality, they will subsidize that and fund it. There are a lot of non-governmental organizations who are willing to give grants, and I know the government is working with many of them, including Melinda Gates Foundation and so on. But we do need to find a way of saying that healthcare is not free. It is just paid for by somebody, either by the government or by the insurance or out of pocket. Mm-hmm. Yeah.
You see, the government has a very strong grip on Kenya's health system, controlling about almost 45% of the country's health systems. Yeah. Then you have, of course, the private sector, doing almost 30%, and faith-based as well as NGOs. And I like the concept that you're talking about, having a decentralized a system. But is it possible, to have a devolved, decentralized healthcare system?
Well, I don't think we can decentralize policy and disease mapping and safe management of healthcare in the country. That, I think, needs to remain at a policy level, at the central government level. But we can certainly decentralize other services, such as which is they're already doing, managing the hospitals and the healthcare facilities. But it goes beyond that, even disease mapping. So whereas when a county government prepares its budget, I'm sure they look at the disease pattern. Is that effective? So a county such as Kiambu County, the lifestyle of Kiambu residents and the Kiambu County residents and the citizens there may differ to those in Kisumu, and therefore the investment needs to match that. So yes, you can, I think, and we should be able to devolve. But like I said, we also need to build sustainable models. So the government has a monopoly in pharmaceuticals. They actually have the power of bringing the cost down through supply chain. Question is, how do we make that more efficient? How do we create savings that we can pass on to the patients? And this is what private sectors are doing. So yes, I think we can, but to some extent we'll just need to also devolve generation of revenue and hold the counties responsible for sustainable models. Mm-hmm. Yeah.
It's true, the government has a strong grip, in the healthcare system in this country. Apart from, controlling the health, majority of the healthcare system in this country. Even in the pharmaceutical industry, I mean, it's the government. The government is in charge of ensuring that there are medicines in this country through the Kenya Medical Services Agency. The government has also has a strong say in the insurance industry through the National Health Insurance Fund. And so you can see the government hands in every aspect of our health industry. Is this healthy at all?
Well, to some extent, it needs to be, but there's, from a policy perspective, I think it's important that there's an oversight responsibility in all aspects, even drug management and registration. But where perhaps the private sector can actually support is how to make institutions more efficient, how to make those institutions more effective, and even non-governmental organizations, how they partner with the government is important. You mentioned mission hospitals who have stepped up and are providing this to bridge the gap. Yeah, but one thing that perhaps we haven't ventured into as a country, and I think we are known as a Silicon Valley in Kenya, is the tech industry. Telemedicine can rapidly bring the costs down. AI can actually build algorithms on patient flow because we have clinical pathways. I know of an institution who have mapped 12,000 clinical pathways in the industry, and they're looking at how to support even Avenue. How does the government now look at that and build indicators that help it even preempt the costs that are coming down? So we really need to find innovative solutions. But to answer your question plainly, the government may not necessarily be required in all the angles, all the places. We can, and in private sector, support the government in doing some of these things with an oversight authority, of course. Yeah.
So which are the areas do you feel the government should have a stronger mandate than the private sector, and where, and on the other hand, which areas do you feel the private sector, should more deeper than the government?
So government and also county governments, I think, are focused and should remain focused in policy and regulatory function. I think that's important, especially at the central government. Drafting integrated plans, service delivery for diseases and mapping and surveillance, and also ambulatory care where required. Where the hospitals and private sector, and not necessarily in the healthcare sector. I mean, I was talking to somebody this morning about an example of where tea estates have actually been able to run their own healthcare facilities within the tea estates. How are they able to do when they're not in the healthcare field? Is there a way we can partner with large organizations such as Kenya Breweries or East Africa Breweries, for example, with Safaricom, who is very key in foundation work, with Avenue Group, which is expanding to have fixed fee or universal healthcare, and Avenue is also already doing that, providing fixed fee services. So in provision of care, in delivery of care, the healthcare private sector can help. The private sector itself can help with corporates and blue chip companies who actually want to do things to help the organization and the government, and they can complement. In technology, I think they could be a partner within the industry. Safaricom comes to mind, providing solutions for telehealth. So you don't need a brick and mortar, you just need a kiosk, for example. Healthcare has been left behind. The banking industry moved way ahead in creating automated teller machines, the ATMs. Where can healthcare providers plug in and move into that industry? And to be honest, just to disclose here, Avenue is looking at those solutions, and you should see a digital in Kenya coming soon from Avenue, especially. Yeah.
Let's also talk about the cost of treatment in this country, and we know that as a country, we are spending about 10 billion shillings to send patients to other countries to access medical services, and this majority of them, they go to India, to USA, to Germany, to South Africa. Why is the cost of procedures in this country expensive?
So It comes in very many angles. One, the cost of equipment and the taxes levied on the equipment, whereas the government has really subsidized in eliminating VAT, for example, on exempt basis on application, helps to bring the cost down. But still, the cost to transport and bring the equipment down, the training of the specialists are not available in Kenya. I was told, I don't know, cardiology, we have only 30 in Kenya.
30.
30, I believe, if that number is correct, the top-notch cardiology.
That is not even enough for each county.
If you look at our WHO says that we need to be at 1 to 1,000 doctors and
ratio,
and 1 to 280 nurses. But where are we today? We are at 1 to 10,000 doctors and 1 to 650 nurses. And we still have attrition of this brain drain of this skilled manpower. How do we bring the cost down? I think we need to relook at the entire continuum of care. Like I said, when a patient gets to decide that he wants to go abroad, sometimes it's not necessarily cheaper. It's just the fact that there's a trust element on the healthcare sector, both in private and public. We in private sector are working hard to get the accreditations to validate our care. We are working towards innovative models to bring the cost down through digital transformation, but it's not enough. The trust element still comes to count. I remember speaking to one of our staff who is actually seeking to go for further treatment in India, and this treatment is available in Kenya. But the cost of care in India is much cheaper because of the mass, the volume that they see. So if we are doing 10 surgeries, they are doing 1,000 surgeries. So economies of scale play. They are overflooded with skilled manpower. I was talking to another person last week about the problem of brain drain of nurses, exiting Kenya and going to UK, especially in recent months. But if we're looking at that as a problem, then we will see it as a problem. If we look at it as an opportunity, then we can be suppliers of nurses to UK, to the world. How do we create many nurses who are available to go and come back? Many come back as repatriates. How do you bring them back through a program into Kenya? And to bring the cost down, we also need to look at the type of treatment we give. Is it something that we can predict early enough in time so that it doesn't hit the patient at the end? So there are many ways of doing this, and we probably need another cup of coffee to talk over that.
Or maybe a cup of uji.
A cup of uji, yes.
I like the fact that you have brought in the issue of a brain drain, and we know that Kenya has really been struggling with this issue, whereby you have a lot of our doctors getting better remunerations in Germany, in UK, in US, in Australia, in Canada, and now even in Dubai. And the same is happening to our nurses, it is happening to our engineers, it is happening to so many people. Is it immoral, number one, for a country to sack its critical personnel, knowing too well that they need more of that, but they continue to sack them more by offering them better incentives because they can afford?
Well, ethical, I wouldn't want to answer that, but opportunity, I think they are not asking people to move to those countries. Kenyans and many people across the globe, even Nigeria for that matter, you get a call for a placement in US, you get a call for placement in Dubai. People are excited about that. And when we speak to our doctors, it's really not about the money at the end of the day. It counts heavily, but it's about, are they getting exposure? Are they learning every day? Is the environment suitable? So if you see a doctor who is coming to a county hospital or a private hospital for that matter, and they find that, look, he's sitting idle, he's not applying his mind for what the training is done for, they get bored, they get not challenged enough. Is the environment suitable? Yes and no. Is the equipment working? Many a times there's a breakdown, and therefore they're not applying. Some have to treat patients symptomatically and to manage the care, at least to keep a continuum of care because of all this. And then there's disparity between one county and another, whereas the salary grading is good, but or is uniform, but the allowances differ from one county in Nairobi to another county, but they're same specialist. And when you talk about brain drain, you can even say that doctors prefer to stay in Nairobi or Mombasa or Kisumu. Even there is a drain within the country. The county of Wajir or the Wajir area, it doesn't get the best of the best because there's a drain from there as well. If you ask yourself, don't we have skilled, qualified doctors coming out of Wajir? The answer is there are many, but they prefer not to stay there.
They prefer to practice in Nairobi.
So, but telemedicine will crack all that. It breaks all the barriers to healthcare access. Of course, we can't eliminate the brick and mortar, but we can certainly improve access and even reduce if we enhance the work environment of the doctors and create an area where they are learning, cross-learning. We can actually have a partnership with, say, Dubai and tell them, you know, we are sending 10,000 doctors this year, but we expect 5,000 back in 2 years. And it could be a rotation basis where there's a symbiotic improvement, right? Yeah.
And I remember, you know, sometimes back in 2017, I can't remember very well, we tried that kind of a model with Cuba, you know, which has one of the best socio healthcare in the world. Unfortunately, we don't have an account of what has been the impact of that and how its sustainability. But do we have a country in the world that has trialed that kind of a concept and succeeded?
I think Dubai is one of them. I mean, there are so many ins and outs in all sectors. Health is up and coming now. Dubai is focused, especially after COVID, in even robotics. But where they are looking at rotating doctors within countries, bringing even civil engineers in Dubai housed there. So I think Dubai would be a good case study to look at how they've modeled. And the doctors don't necessarily stay there for 5 years, 10 years. They are also rotating. We also need to be wary about our caseload in Kenya. I mean, do we have enough caseload for those doctors to keep busy? Or do we need a kind of a camp that is rotated? And this is where Avenue is trying to break those barriers, where we have specialists coming down every so often we build enough caseloads so the doctor feels motivated enough to come to Kenya and pass on that skill to our doctors locally. So yes, maybe Dubai would be a good case study.
And let's face it, I mean, health equipment are very expensive, and you know, investment in healthcare, and you know this better because you're in that field. And I was shocked, almost gobsmacked when I discovered that, you know, the cost of one PEP scan is almost $1 billion shillings. And how many institutions can afford 1 billion shillings just to buy an equipment and install it? And you're not factoring in the cost of repairing, running that system, the cost of hiring expertise and all these. But let's face it, the government has also invested heavily in the healthcare industry, and a good example is Kenyatta University Referral Hospital. It has some of the most modern health equipment in the world. So, and I know there are plans to construct about 10 of these kind of institutions in the country, but of course funding is always a challenge. Is there any way that you know, you can create a partnership between the private and the public sector to ensure that some of these challenges are offset by the symbiotic relation?
No, absolutely. I mean, you mentioned PET scan, and yes, do we have enough caseloads across the country? I mean, you're a population of 50 million now and growing. Do we have that kind of a population that can utilize that equipment effectively across the country? The answer is yes. As you go along, the NCD pattern shows us, non-communicable disease pattern shows us that the demand for that equipment with our lifestyle will be there. So yes, partnerships are important. Leasing is also an important. But from where technology is going, I was told soon we won't even need that big MRI or CT scan.
Yeah.
You will probably just be able to do this at or with your phone or on a desk and not need that equipment. So I think the way healthcare is going, there is a lot of focus in bringing innovation into it and bringing the cost down. So I wouldn't be surprised in the future where even that PET scan is much lower in cost. But the investment in the innovation, the investment in the intelligence is what we need to make sure it doesn't then become that I've invested X amount of billions of dollars and therefore I need to recoup it. We need to look at healthcare as something that everybody deserves to get, and we need to look at it as a giving back, not an investment. Yeah.
Finally, Osman, before I let you go, is it all doom and gloom in Kenya's health industry?
Absolutely not. I think we've come a long way. We have a lot of private hospitals that have come up and bringing down the cost. Their focus is quality. We have the government institutions that have devolved and are investing in a lot of facilities. We have mother and child healthcare programs that are looking at preventive of maternal health. So there is a lot of hope and there is a lot of interest in healthcare, including from the investors who are really looking at giving back to the community. And the healthcare sector is one area where even private investments are coming through just to have an impact in the country. Very good. Yeah.
Imran, thank you very much indeed for finding time to be with us this morning, and of course for sharing with us your inputs and your insight as well.
It's a pleasure. Thank you very much.
Well, we've been talking about the cost of healthcare in Kenya with the CEO of Avenue Group, Imran Osman, and of course we have benefited immensely from his insight on how we can bring down the cost of healthcare in this country, and of course how we can streamline our policies and our investment in this critical industry. Well, we have to come to the end of this conversation because Kurunzi Mashinani is coming up next, and thereafter we shall have the lunchtime news. So from me and the rest of the business team, Asante Sana, enjoy the rest of your afternoon. Let's keep talking. O'Brien, Kimani. Have a good afternoon.